And my topic on sepsis is today antibiotic stewardship in sepsis, optimizing therapy for precision care. And the lecture will be totally based on the Surviving Sepsis Campaign Guideline 2021. Before going to my introduction, I would like to highlight few things. And as you all are aware, sepsis, and you have heard about the comprehensive definition of sepsis. So it is life-threatening multi-organ dysfunction due to an infection due to dysregulated host immune response. So basically, if a patient going to become septic, there has to be three factors. That is infection. Usually sepsis is related to bacterial infection, and then a dysregulated host response, which is causing life-threatening multi-organ failures. So if an infection is in the food, still there is a possibility of having a dysregulated multi-organ failure due to a dysregulated host response. So my point is, once the patient is in sepsis or in septic shock, giving antibiotic alone won't survive the patient. That is one point. But my lecture will totally concentrated on how to give antibiotic, the dose and the right antibiotic and the right time. But still, the survival, the outcome or the prognosis can be poor, because we all don't know what is this X factor. Basically after infection, how this multi-organ dysfunction, life-threatening multi-organ dysfunction happens due to the abnormal host response. What are the triggering factors? Still, we don't know. So that is why giving antibiotic alone sometimes will have a good prognostic time, but it doesn't mean administration of antibiotic is paramount at the right time for the survival of sepsis, but there are a lot of gray areas. And the second thing I would like to highlight, as Dr. Anuruddha said, the local epidemiology and those things differ from country to country. So still, though these are guidelines, still clinicians' judgment and the clinical decision making also play a vital role for the survival of a patient who is coming with sepsis. So my introduction would be why we are talking about antibiotic stewardship in sepsis. Even when we are going to talk about sepsis as consultant clinical microbiologists, we have a dilemma. Basically, we have to save the patient, and also meantime, we have to think about, or we have to prevent multi-drug resistant development of multi-drug resistant bacteria. So that is our job. We are always in a dilemma. Sometimes, definitely we have to start antibiotic. Unlike other clinicians, in the back of our head, we are thinking about, are we promoting antimicrobial resistance? So that's why the stewardship word is there even in sepsis. So the main aim, optimize the patient's outcome. I think that is the first thing, the paramount thing. If antibiotics are needed, if even broad spectrum antibiotics are needed, you have to start it. Then from patient's point of view, we have to minimize adverse events related to antibiotics. And as I said, the last thing would be combat antimicrobial resistance, because antibiotics are called magic bullet, but unfortunately, due to AMR, antimicrobial resistance, we are losing the power of this wonderful drug, the magic bullet. So we have to always think about combating antimicrobial resistance when we are administering antibiotic, even in septic patients. So there are a few points I want to highlight, which was highlighted in the survival sepsis document. The diagnosis and initial antimicrobial therapy. So once a patient is in the ETO in the ward with the possibility of a sepsis or septic shock, so that is a clinical decision. I mean, it is totally a clinical decisions at the beginning. So we need to continual re-evaluation for alternative diagnosis. I think you all heard Dr. Mahen Kotalawala said there are a lot of infection, sepsis mimicking conditions, which can be inflammatory, which can be malignant, right? Heart failure. So always the re-evaluation should be there. If the infection is unconfirmed, I think at the beginning, the majority of cases, the infection is unconfirmed, and the rationale for this is sepsis signs are non-specific. So that is why we can't, on clinical judgment, we can't 100% diagnose sepsis, and even we don't have a biomarker yet 100% accurate of diagnosing sepsis. So if an alternative diagnosis is made, the discontinuation of empirical antimicrobial is recommended. The second most important thing is, so if you want to confirm the clinical condition which mimics or which fall into the criteria of sepsis, finding out the etiological microbiological diagnosis is also paramount important. So to find out that, the most important thing is timely microbiological culture. So before giving antibiotics, always according to the suspected source, you have to take cultures. If you are suspecting septicemia, you have to always take blood. If it is pneumonia, and if the patient is ventilated, you have to take ET secretions. And if you are suspecting urosepsis, urine cultures, all cultures you have to take before starting antibiotics. So obtain appropriate cultures before antimicrobials without any delay. So that is also strongly recommended. Having said that, I have to say, again, if you go for the definition, when the patient is in sepsis or septic shock, it is not, at that point, it is not only purely the infective agent is causing the clinical condition. So sometimes patient is septic or sepsis, cultures are negative, but still it can be a bacterial infection. So that is also you have to keep in mind. So you have started empirical antibiotics, but all the cultures are negative, but still you need to continue antibiotics. So then the second most important point is, I think this part was comprehensively covered by Dr. Nandana. So I'm just reconsolidation the things he said. Time to antibiotics. So at what time you should start antibiotics? So it says, if you are suspecting sepsis or septic shock, administer antibiotic immediately, and it is at least within 1 hour in septic shock. So the second thing is, the possible sepsis without shock, you have some time to see or to reassess the patient to confirm whether it is an infection or not. So assess infection likelihood within 3 hours. So you can wait. If the patient is not in septic shock, actually, if the patient is in shock, and if there is a high possibility of sepsis, you don't have any time, give one shot of empirical broad spectrum antibiotics. We are not worried about antibiotic stewardship at that point. But if the patient is in septic shock, as I said before, as microbiologists or as clinicians, we have to think about AMR also, so we can wait until within up to 3 hours. And low likelihood of infection, and even without shock, you can actually defer antimicrobial. Sometimes you can wait until the final investigations are there. So the rationale behind this is early appropriate antimicrobial administration is critical in septic shock to reduce mortality. However, this must be balanced against the harms of unnecessary antibiotic use. The urgency for immediate antibiotic is strongest in septic shock. Biomarker, the next main point is biomarkers to use antibiotic. With the current evidence, avoid using procalcitonins to start antibiotics. So as I said before, there is no ideal biomarker to say 100% or comprehensively this is sepsis, and no exception for procalcitonin. So you are not waiting. It is just the clinical judgment, and the guidelines just before describe, I mean basically Q so far, SIRS, those clinical judgment will drive whether you are going to start antibiotic or not. You are not going to wait until the procalcitonin results is available, because the current evidence does not support a benefit in short-term mortality, ICU, hospital length of stay, or long-term outcomes when using procalcitonin to guide antimicrobial initiation in addition to clinical evaluation. Then the choice of antimicrobials in sepsis or septic shock. So you have to, most of the time when you are starting empirical antibiotics, you have to start a broad spectrum antibiotic, because we don't know the exact causative agent. The usage of empirical MRSA cover. So as you all are aware, the MRSA organisms has a different antibiotic spectrum. Some of the antibiotics, the broad spectrum antibiotic we are using to treat some of the infections doesn't have MRSA cover. It is a different type of spectrums of antibiotics we have to use if you are suspecting MRSA infection, for example. And we all think some things giving meropenem will cover all the almost possible organisms, but not, because meropenem doesn't have a cover for MRSA. So there are different set of antibiotics. So sometimes at the initial stage, we need to start a broad spectrum antibiotic coupled with the antibiotic which has a MRSA cover, like vancomycin, teicoplanin, or linezolid. But we are starting MRSA coverage if the patient has a high risk of MRSA colonization or MRSA infection. So that is again with the clinical history and the past medical history you can judge. So the tail MRSA coverage based on the patient risk factors and local epidemiology. Unnecessary MRSA coverage carries risk of harm and resistance. Then double gram-negative coverage if MDR risk is high. Now this is mainly applicable for, in our settings, in neutropenic septic patients. So the patients who are coming with neutropenia, usually we encounter a lot of patients who are having cancers and on chemotherapy and then coming with neutropenic sepsis. So they have a lot of the recent hospital admissions. So there is a high risk of having a MDR gram-negative organisms. On those instances, we have to give double therapy. Sometimes we are using 2 antibiotics in different classes to cover gram-negatives, but avoid dual gram-negative once susceptibility is known. And if the culture become positive, and if you identify a organism with the known sensitivities, on those instances, immediately we have to stop this double gram-negative coverage. The rationale is empirical combination therapy for gram-negative coverage is primarily for patients at high risk of MDR pathogens to ensure initial adequate coverage. Once susceptibilities are known, de-escalation to monotherapy is generally preferred. And what about empirical antifungals? So it is the same. Empirical antifungals at the beginning, only as we are going to start at the beginning only in high-risk patients. So the rationale is empirical antifungals are beneficial only for specific high-risk patient populations. Unnecessary use will increase the cost and potential for adverse effects. Consider risk factors like previous Candida colonization in multiple sites, neutropenia, immunosuppression, severe illness, long ICU stays, central venous catheters, the patients who are on TPN, patients who are already on broad spectrum antibiotics, GI perforations, surgeries, acute or renal failure, severe thermal injury, prior surgery history. Those are the patients who have a high risk of, even at the beginning, having sepsis due to fungal infection. And I want to highlight one point here. Especially in neutropenic patients, I mean, I mean, the patient can be going to sepsis or septic shock in otherwise normal patients, and these neutropenic patients, immunocompromised patients, are different categories. Actually, we don't have time. I mean, we can't think about very rational the management in these sort of patients. So if you are suspecting, if there is a high possibility of MDR coliform, sometimes if you are suspecting fungal infections, initially you have to cover all those things, but later once you find the positive agents, you can de-escalate, because in septic or sepsis shock, especially in neutropenic patients, you have a very limited time period to save the patient. What about routine antivirals? Usually, unless in specific outbreaks, it is not very strongly recommended to start at the beginning, because it says viral infections are rarely the primary cause of sepsis outside of specific epidemics or pandemic, and the management of specific viral infections like influenza or SARS-CoV-2 should follow dedicated guidelines. And what about administration of antibiotics? I mean, is it differ from administering an antibiotic who are not septic? And it has found, I mean, during this sepsis or septic shock process, the lot of biochemical changes occur inside our body. As a result, you have to have a very thorough knowledge about the individual pharmacokinetics and dynamics of the specific antibiotic. So it is recommended use prolonged infusion of, if you are using beta-lactams, use prolonged infusion of beta-lactams after the initial bolus dose. The rationale is prolonged infusion help maintain therapeutic concentration of beta-lactam all the time, which may reduce short-term the morbidity, but a loading dose is essential. And optimize the dosings using, as I said, the individual pharmacokinetics and dynamics of the drug. Adjust dosing for altered drug kinetics in sepsis, and the rationale is sepsis significantly alter pharmacokinetics and dynamics of the drug, potentially leading to subtherapeutic or toxic drug levels. Dosing adjustments based on PK/PD principles, ideally with clinical pharmacist input and therapeutic drug monitoring or dosing software, improve the likelihood of effective and safe drug concentration. So it is say you need to get a help of a clinical pharmacist. Unfortunately, I think this setting, I mean this the multidisciplinary team approach, especially getting the advice from the clinical pharmacist, it is very rare in the Sri Lankan settings. But if you want to move forward, if you want to have a good outcome in sepsis, the patients, as Dr. Nandan said, this multidisciplinary approach is going to be very important. And the other point is the source control. And with my clinical experience, I think that giving the right antibiotic at the right time is very important. But in my opinion, this source control, I mean the controlling the source is very important. But unfortunately, I have to say, sometimes in our settings, with our experience, we give a very minimal attention for these source controls. So if you see in septic patients in Sri Lanka, I have seen a lot of septic patients coming with necrotizing fasciitis. And as you all are aware, necrotizing fasciitis is usually still caused by group-based streptococcus. So the drug of choice is not meropenem, because the universal, still group-based streptococcus is universally sensitive to penicillin. So you can treat these patients with penicillin plus clindamycin. But the most important point is, from the beginning, at the start, get the help of the surgeon and do a thorough debridement. But unfortunately, sometimes this is not happening. So identifying and managing infection source rapidly is very important. If there is an abscess, draining, if the infective focus is the infective device, remove it. And the rapid prompt source control is really fundamental for sepsis management and is associated with improvement of the survival. And if the suspected source is IV lines, you have to remove. But practically, there are a lot of challenges. We are daily getting the positive line-associated infections in renal unit who have IJC lines. But definitely you need to remove it. But unfortunately, IJC lines are very costly, and if you remove it, you don't have another IJC line to replace it. So there are some practical difficulties, but it is quite difficult to control the sepsis unless you are going to remove the source. The removal of potentially infected device is crucial for definitive source control. And what about the de-escalation and the duration? As I said, we have to always give antibiotic at the right time, and meantime also, if it is unnecessary, you have to stop it immediately if you are given the right duration. So reassess daily for de-escalation opportunities, and they use shortest effective antibiotic course. Rationale: the daily reassessment and de-escalation reduce the antimicrobial resistance and adverse effects and may shorten hospital length of stay. Rapid diagnostic technique should be utilized to facilitate this. The classical example is if a patient coming with necrotizing fasciitis in septic shock, we don't know the cause. We may start on meropenem like broad spectrum antibiotic, but then his tissue culture or the blood culture is positive for group A streptococcus. As I said before, it is universally sensitive to penicillin. So start a narrow spectrum antibiotic like penicillin, replacing meropenem. Definitely it will reduce the development of carbapenemase resistant organisms due to unnecessary use of carbapenems. And the duration of antibiotic for adults with an initial diagnosis of sepsis or septic shock with adequate source control suggests using shorter over long duration of antimicrobial therapy. The rationale is short courses, when clinically appropriate, are less costly and have fewer adverse effects without compromising outcomes. Optimal duration depends on host, microbes, drug, and anatomical site. If you are done the source control at the beginning, definitely we can short the duration. The biomarkers to discontinue antibiotic like procalcitonin for adults with an initial diagnosis of sepsis or septic shock and adequate source control where optimal duration of therapy is unclear suggests using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials over clinical evaluation alone. So to discontinue antibiotic where there are don't have definitive evidence for the control of the infection, there is a place for biomarkers like procalcitonin. The rationale is procalcitonin in conjunction with clinical evaluation can help guide discontinuation of antibiotics, leading to reduced antibiotic exposure without negatively impacting mortality. This is particularly useful when the optimal duration of therapy is not clear. Availability of procalcitonin testing should be considered, and it is freely available in Candid. So, what are the key principles for sepsis antibiotic stewardship? Timeline. Initial appropriate antibiotic start should be prompt, especially in septic shock. Appropriateness. Choose empirical antibiotic based on the patient risk factors, likely pathogens and local epidemiology. If there is MRSA risk, you have to start empirical MRSA antibiotic. If there is a risk for MDR coliforms, you have to start the double therapy. But once you have found the cause, narrow the antimicrobial spectrum or discontinue unnecessary agents as soon as the microbiological results and clinical improvement allow. The optimization, you need to optimize the drug according to the PK and PD principles for dosing and consider prolonged infusions for beta-lactams after the first dose, bolus dose. And source control, prioritize these and implement source control measures rapidly. and the duration aim for shortest effective course of therapy, and the re-evaluation continuously assess the need for and the appropriateness of ongoing antimicrobial therapy. And as I said, all the speakers said the multidisciplinary approach is paramount, involving infectious disease specialists, clinical pharmacists, and microbiologists in decision making. Thank you very much.